Jen, this is Stacy Danoff. I'm seeing it's waiting to live stream when I'm on YouTube. So let me do some double checking here. Oh, nope. We might be live. Hang on. Just got a notification. We are live. There's probably like a 30-second delay.
Awesome. Well, all right. Well, then on that note, I will welcome everybody to the July 2024 Acute Care Transitions Council meeting. Before I call the meeting to order, Jennifer, will you conduct a roll call to verify quorum, or if we are proceeding with this as a working meeting, which we kind of assumed it would be, recognizing that if we don't have a quorum, the council can still complete the tasks that help us move forward with the report, but we are just unable to make any recommendations or decisions that would require a report.
Okay, I can do that. Let me pull up my document here, and I can do that in a second. All right. All right. Sorry, I just got a little bit lost in everything I had open. So let me take a roll call here. Laura Arnold.
Here.
And Carol Brackstrom.
Here, thank you.
Randy Baumgart.
Yes. Yeah, here.
Okay, perfect. Josh Bird.
I am here, yes.
Tom Delaney. Jody Donne. Sheila Grissom. Brad Johnson.
Here.
Perfect, thanks. Mary Kosing.
Here.
Natasha Mertz.
Here.
And Nicole Vujic. Susan Pleasant.
The ones that we were considering.
Jessica Simisak.
I'm going to jump in and say Jessica's trying to get in. Oh, it looks like she just got in. Let's see.
Okay, Jessica, just a verbal validation you're here. I see you.
Yes, I'm here.
Perfect. And Kathy Shavers. Janelle Hubbard.
I'm here. Thank you.
Okay. And Cindy St. George.
I'm here.
And Simon Warren. All right. And Sheila Grissom, I see you. Is that right?
I'm here. You called my name previously.
Oh, okay. Sorry, I didn't bold you when I should have.
No problem.
You're bold now, Sheila.
Perfect. You have 11 people, Josh, and 10 is needed for a quorum.
Perfect. All right. Well, with that, then I will call the meeting to order. And I can't really see your screen because I have mine open on multiple, so I don't see what slide we're on. Oh, there we go. Perfect.
Well, you just called it to order.
Yep. You just called it to order. Oh, go ahead.
Something we just added at the last minute, Josh, sorry, I'll put this out here as the facilitator, just a reminder to check email, for the council members to check email for things that require signature, like the oath of office and other documents for review. And then I just transitioned over to the purpose of the council.
Yeah, no, so I can see it now. So yeah, as a reminder, we added the purpose of the council and the next slide to the beginning of the meeting, just to remind folks of why the council is meeting, and to kind of just level set a bit with that we added the vision to the introduction, and this is the vision of our work. So I will move on, and just before getting into the meat of the meeting here, just want to remind everyone of the public that are viewing today that can do so. And I can't tell if Natasha, well, I see you're in St. Cloud, or no, you're in Elmer Andersen, the cloud room there. So if anybody is in there, are able to view it that way, or to communicate and provide public comments later on in the meeting. Also, if you're watching this live on live stream, just note that there's a 20 to 30 second delay between the meeting itself and it being live streamed. Comments can be submitted listed there, as always, and then there will be an open session that will take place between approximately 2:55 p.m. to 3:10 p.m. Comments, as always, again, are welcomed and encouraged, and then all public comments are being sent directly to each council member, analyzed for themes, and will be considered when the council develops recommendations within the final report.
Josh, I'm sorry to interrupt for 1 second. I forgot to, we try to record the meeting as well for the purpose of minutes. So if I could start that now, that would be great.
Certainly.
Okay, sorry for the interruption.
Nope, you're good. So since we do have a quorum, I will ask here's the working session agenda, or the agenda for today, and just if there's any questions, or if none, just seek somebody to make a motion to approve the agenda.
I approve.
This is Brad, I'll second.
A motion from Laura, a second from Brad. Hearing no further discussion, all those in favor, please say aye.
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 Opposed? All right, perfect. We have an agenda that passes. And then the minutes were distributed for everyone's review. Are there any corrections or additions to the minutes? Hearing none, can I get a motion to approve the minutes from the June 4th meeting?
I approve. This is
Second,
Jessica. I
Sheila.
can second.
I heard a motion and a second. I will leave it up to others to determine who that was. Hearing no further discussion, all those in favor, please say aye.
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 Opposed?
So Josh, just to interrupt for a
Yeah.
second, for the purpose of minute taking, if I have this correct, Laura, you motioned to approve the minutes. I did not get the second.
This was the second.
I think I seconded and Sheila did at the same time.
Thanks, Jessica.
So we'll go with Jessica as the second, if you got that.
Perfect, thank you.
Yep. All right, I will turn it over to Laura then.
Okay, this is Laura, one of the co-chairs, and we are going to have a Department of Health study presentation. So I'm going to hand it over to Nathan and Kristen to start their presentation.
All right, Nathan, you're still on mute, I believe.
Always someone in these meetings, right? It's gotta be me. So thanks, everyone. I'm just about to bring up my slides here. Just one second.
And you have plenty of time because we started a little early, so
Good. Okay.
no worries.
Okay, so thanks for inviting me here. My name is Nate Hillmeyer, and I'm a senior researcher at the Health Economics program at the Minnesota Department of Health. And with me today is Kristen Dillon, and she's the Associate Director of Research at Wilder Research. And she led the team partnering with us to complete this study and is going to co-present the findings with me today. And also with us, we have Stefan Gildemeister, the Director of the Health Economics Program, and he might give some additional context and observations. But before I get started, I just want to express deep thanks and gratitude to Dr. Frangel for helping us get the project scope and the tools in this study. I also want to offer sincere recognition to the hospital staff who share their time, energy, insight, and experiences with the state of Minnesota to help inform this study. And their contributions are really invaluable in producing these important results that we're going to share with you today. So on the following slides, Kristen and I are going to walk through how this study came about, why it was implemented, and what some of the key takeaways are. I'll quickly mention that the Minnesota Department of Health is committed to using evidence to improve the ability of Minnesotans everywhere to get the care that they need at the right place at the right time. And we also have an eye on advancing health equity. So as you might know, the mental health and addiction treatment system often fails to serve Minnesotans experiencing a behavioral health crisis. So patients can be deemed ready for admission, transfer, or discharge in the hospital, but remain for days, weeks, or even longer in hospital emergency departments and inpatient psychiatric units. So these delays can be stressful to their family members, caregivers, and hospital staff as well. So the purpose of the study is really to measure the reasons for behavioral health transfer and discharge delays. And I view this as being very complementary to the work that you'll hear and have already heard from Minnesota Hospital Association to track overall volume of delayed patients. But really we want
Nate, I'm sorry to interrupt. We cannot see your slides if you're sharing them. Perfect, thank you.
Great. Thanks for that, Kristen. So as I was saying, let's see. So the purpose of the study is really to identify where the breakdowns in the system occur, particularly when multiple settings are involved in a crisis of a behavioral health patient, the stabilization of that patient, and the overall treatment. And like I was saying, I really view this as complementary to measuring the overall volume of delays. And this really focuses in on the reasons for the. So to give you some background on where this came from, Kristen and people at the Minnesota Hospital Association pioneered this data collection type of study back in 2016 and produced a report in 2017. And she also took this study out to Maryland and produced a similar study as well. And MHA and Wilder also had conversations in 2019 to kind of further the discussion. And subsequently, between 2017 and 2022, here at the Minnesota Department of Health, we completed 5 public interest reviews that were all related to inpatient mental health expansions and issues with inpatient capacity for mental health patients. So we were very interested in measuring and using evidence to see where those breakdowns occur. In 2022, as you might know, the Minnesota legislature temporarily lifted the state moratorium on hospital beds for expansions in inpatient mental health services. At the time, the Minnesota Department of Health was tasked with monitoring the expansion that happened, that was approved in 2022 behind the state capitol building by Acadia Healthcare and Fairview Health Services, as well as any other new expansions. And part of that legislation also required us to develop a legislative report on the access and quality of inpatient mental health services across the state of Minnesota. And we've been working since that time to really develop a framework of measuring those access issues. And this study is a key component of that study, of the report to the legislature. So now I'm going to hand it off to Kristen Dillon, who can quickly introduce herself and describe the data collection and limitations of the study.
Thank you, Nate. Hi, everybody. I'm happy to be here. I'm Kristen Dillon. As Nate said, I'm the Associate Director of Research at Wilder Research, and I've been very fortunate to get to work on every iteration of the study that my organization has done. So we're really excited to have new updated data to share with you today. So for this particular study, the Minnesota Department of Health invited all 128 hospitals across the state to participate. After they did their broad invitations, 34 hospitals agreed to devote their scarce staff time and resources to this effort, which we're very thankful for. And the resulting sample covered all regions of the state, but we do acknowledge it was more representative of some areas than others. I think it's important to note that the 34 hospitals that participated included 18 emergency departments and 5 inpatient units in greater Minnesota, with 11 critical access hospitals represented in this sample. Next slide, please. So for this study, we had a data collection window that spanned from September 5th of 2023 through October 20th of 2023. Within that broader window, each of the participating hospitals was able to select a specific 14-day data collection period that they thought was most conducive to collecting data on behalf of their patients. The information was collected only with regard to patients who were in the hospital for a behavioral health issue as a primary diagnosis, and only those who were considered delayed. And so for the emergency department, that meant that if a patient was in the emergency room or the emergency department for 4 hours after a decision about where they should receive care was made. So that's the same definition that is used for the Joint Commission. It's a standard definition of boarding in an emergency department. For the inpatient side of the study, when a patient was stabilized and ready to be discharged, but unable to be discharged or transferred for whatever reason, that's when their delay started. So only patients that experienced one of these definitions was included in the study. They were included in the study. Because we understand that reasons for transfer and discharge delays are complicated and they can result from barriers and systems that are both inside and outside of hospitals, it's really critical to understand what those deep issues are. And so we collected a lot of different facets of information about a patient experience. This included how patients arrived in the emergency department or the psychiatric unit, demographic information such as age, race, ethnicity, insurance coverage type. We collected in-depth information about the reasons for their discharge or transfer delays, and we collected patient characteristics that hospital staff believed contributed to the delay, such as whether the patient had a substance use disorder, developmental disabilities, or autism, they were experiencing housing instability, or they had significant medical comorbidities. We also wanted to understand where patients ultimately ended up. So we asked for discharge information, including the destination. I'm going to transfer back to Nate for the emergency department findings.
Yeah, thanks, Christy. So within the 2-week window, this was really only 14 days we found across the participating hospitals that there were 534 patients that were boarding in emergency rooms. And these patients collectively were delayed for 560 days and had to wait more than a day on average before they left the emergency department. And the majority of boarding patients in emergency departments were waiting for hospital beds, which might be unsurprising. But we're also interested to find that there were other reasons as well. And so those included a delay in creating or implementing a care plan or executing the medical doctor's orders. Sometimes there could be delays related to patients needing a transfer to chemical dependency treatment facilities or care beds, which are state-operated addiction recovery beds. And finally, patients could also be delayed due to non-adherence or refusal to placement. So nearly all patients in the emergency department transfer discharge delays in study were Minnesota patients. And the greatest representation of patients were from Hennepin County and Ramsey County. About 3/4 were age 18 to 64. 20% were under age 18, and 7% were age 65 and older. About 1/3 of these patients were Black, Indigenous, and people of color, and about half were women. So more than half of the patients were insured by medical assistance or Medicaid or Minnesota Care, and 21% were insured by Medicare, and 26% had private insurance. And I'll pass it back to Kristen to talk about the inpatient side of the study.
Thanks, Nate. So again, in this 14-day window, there were 182 behavioral health patients who experienced a discharge delay in an inpatient setting. That accounted for approximately 17% of the behavioral health patients that were in these hospitals that participated in the study. Collectively, that 182 patients had a discharge delay of over 1,400 days, and an average was over a week at 8 days. Next slide, please. The reason that affected the most patients who experienced a delay was a lack of intensive residential treatment services or an IRTS bed. So that accounted for about 18% of patients. It also accounted for the largest number of discharge delayed days. So a total of 250 days waiting for an IRTS bed. The second reason that affected the most patients was a delay due to a patient civil commitment. That affected about 13% of the patients in this study, and it accounted for about 197 delayed days. And then we also had reasons such as care not being available in a chemical dependency treatment or care facility, as Nate mentioned. It was similar between inpatient and emergency department there. We also saw reasons such as a community behavioral health hospital, bed not being available, waiting for min choices process or a CADI waiver, group home beds not being available, or nursing home or memory care beds not being available. And I just want to pause and note that we asked for about over 21 reasons on both of these, the inpatient and ED side. So these are just the top ones that we saw. Demographically, on the inpatient side, more than half of the patients identified as men, about 57%, and about 3/4 were between the ages of 18 and 64. Almost a quarter identified as African American or African born. We did look at some comparisons in demographic characteristics and how that affected discharge delays. And notably, patients who identified as another race or ethnicity other than white or African American or African born accounted for only 16% of patients, but they had the highest median number of days at 11 days compared to their counterparts. Similarly, women tended to have a higher median number of days compared to men. So women, the median number of discharge days that they experienced was 10 days, whereas men experienced a discharge delay of about 7 days. And that difference was statistically significant. In addition, similar to what we saw on the ED side, about 3/4 of the patients that experienced a discharge or transfer delay were insured with public forms of insurance. So 3/4 were insured by Medicaid or Minnesota Care, and 1/3 were insured by Medicare. And patients who were uninsured, although again, it was a smaller proportion of patients, they tended to have a higher median number of delay days at 12 delay days. So, this was a high level snapshot. We had a lot of data that we tried to summarize here for you today, but some of the main takeaways that we're hoping that you walk away with are that discharge delays are affecting many behavioral health patients in inpatient and emergency department care. And so we're talking about hundreds of patients within this specific 2-week period. I know that our partners at the Minnesota Hospital Association are going to give you a broader snapshot shortly. But these delays, regardless of what the time frame is, are really difficult for patients. They put strain on a hospital system. And given that the majority of the patients in this study are experiencing delays in both inpatient and emergency departments, and they're relying on public insurance, these delays can also be really costly to our society. This study, as Nate mentioned earlier on, is largely a continuation of similar work that we did in 2016, 2017. And what's really interesting is that there are some systemic issues that we're seeing across both studies that are still affecting patients. And so it's really important to highlight that there is still a critical need to address issues that are persistent over time. With that being said, some of the more recent top underlying reasons have shifted some since 2016. And so it's part of why capturing more recent data is really important. And we know our society has been through a lot since 2016. So some of the biggest shifts that I just want to highlight include the overall frequency. We saw an increase in delays for patients with civil commitment processes, and an increase in delays for patients because of a lack of nursing home bed or memory care beds. On the flip side, we saw that community behavioral health hospital beds, although it was still in the top set of reasons, it was less prevalent in this current study than it was in the 2017 study. So we are hopeful that these findings can be used to leverage support for increasing the necessary infrastructure in the behavioral health care system, and the external systems that surround hospitals, such as the legal system, the long-term care system, in order to reduce the prevalence of discharge delays. And we're hoping that policy supporting the movement of patients out of the hospital and into settings that are more appropriate for their care in a more timely fashion, streamlining the legal decision-making processes and reducing other administrative barriers may have the potential to stabilize, if not improve, the ability of patients to receive care in the right place at the right time, which I know is all of our goal. So next, or did I miss a slide here?
No.
Okay, thank you.
Yeah, thanks, Kristen. So a continuation of what Kristen was just saying, the most common reasons for discharge delays were a lack of available beds in a safe setting. And so as Kristen described on the inpatient side, that was really the intensive residential treatment services, as well as the eviction care facilities. And those reasons alone accounted for almost 60% of transfer and discharge delays in inpatient units and 30% of discharge delays in emergency departments. And the results also indicate that if patients were able to be discharged for inpatient care to a residential or chemical dependency treatment facility, then fewer patients would likely experiencing a discharge delay in the emergency department. And so this is kind of an upstream downstream effect where people are boarding in the emergency department because patients cannot be discharged in the inpatient setting. That was really driving lot of this study, and why we're very excited about sharing this with you, because I think it pinpoints some of those stubborn issues that Kristen was talking about that have been in place since 2016, but are still with us today. And I just want to say, during this 14-day study period, which is a very short time frame, and we did that to try to alleviate burden on hospitals for committing their scarce staff time to tracking this information and really giving us a robust sample. But during that 2-week period, we found that 311 fewer unneeded days in emergency departments occurred, which is kind of staggering when you think about it. And the lack of residential treatment resulted in over 400 unnecessary days in inpatient units. So it's critically important to kind of assess, where those needs are across the state. So nearly half of patients experiencing delays were eventually transferred from the ED to inpatient psychiatric units, and 26% were transferred from inpatient units to residential facilities. And so what this tells us is that these settings are available across Minnesota, but they're really not as available or widely available as they might need to be for the optimal flow of patients.
And as I mentioned, in addition to gathering information about the reasons that patients were delayed, we also gathered information about the characteristics that contributed to those delays. And so the most common patient characteristic associated with transfer or discharge delays across both inpatient and emergency department settings was a history of behavioral issues or dysregulation for younger patients and substance use for adults. In addition, complex healthcare needs such as dementia, traumatic brain injury, physical disabilities, medical comorbidities tend to affect a smaller number of patients, but it still had a larger effect on the duration of days that they were delayed. So we really want to highlight that ultimately these are individual patients who may not fit within the overall pattern, but there's a large impact on their lives because of their needs. Therefore, it's really important to consider the availability of community-based support specifically for different types of patients, and making sure, as Nate was saying, as we're thinking about the overall infrastructure, that there are places for patients that have complex needs. And for patients with discharge delays in both settings, many of them ultimately ended up going home either with or without support services. And so and that was particularly true for youth who experienced a discharge delay. And so it's really important, as we're thinking about building capacity, that we're thinking about not only residential facilities, but also community-based outpatient services that can support individuals who are going home from hospital care, especially if they're going home because there's no space available in a residential side.
So we also wanted to point out that one of the key takeaways from this study, and one of the objectives in really designing the study was to try to assess how patient populations across Minnesota might be experiencing discharge delays differently. And we did find that African American or African-born patients were experiencing delays disproportionate to the overall share of inpatient behavioral health patients, and that really stood out to us, and it's kind of shocked us, honestly. It kind of brings an attention to the need to advance health equity as part of this study, and for us in Minnesota. But similarly, we found that people covered by public insurance and Medicaid and Medicare also had a disproportionate representation of discharge delays that weren't commensurate with the overall share of inpatient and emergency department behavioral health patients. So part of this study is to try to reflect on the implications, and I think one of the key considerations for this group and other groups is to to really examine the recent report, I think it was issued in January, recommending reimbursement changes for community-based behavioral health services to cover the cost of providing care for many of these patients. So I'm about ready to wrap up here before we open up to questions, but I did want to share that we had tentatively scheduled a release for today. However, life happens and things get delayed, unfortunately. And so we hope to have this report out, if not today, in the next few days. And so I look forward to sharing that with you and everyone else when that happens. And beyond today, the next couple of days, we're really going to discuss and plan for a need for additional data collection. We know that this study wasn't perfect, and more study is potentially, and there are ways to improve this. But one of those key improvements would be to have more robust sample of pediatric patients. And so during that 14-day window, for whatever reason, on the inpatient side, we didn't catch as many patients that were being delayed in the pediatric side of the population. And so we hope to kind of expand this both to that population and to include other hospitals that haven't yet participated. So we look forward to continuing this work as well as continuing the preparation for the 2027 report of legislature I mentioned before on access to quality. And with that, I will open it up to questions.
I have a question for your future research. Are you going to expand that definition if you want to capture more of the pediatric population to shelter placement as well as behavioral, because those patients tend to experience longer boarding?
Yeah, no, I think that's a great idea. I think part of the advantage of coming to this group and others is kind of improving the study. Like I said, we know that the study isn't perfect. We do want to expand it and kind of pinpoint where those reasons for the I think it's probably fair to say that the patients and the shelters might be experiencing different reasons for delay. We need to kind of put that apart as well. So it's not bring that to us.
This is Janelle Hubbard from Anoka County Public Health. Thank you so much for this information. It's very helpful. My one question that I have is if this really does capture a lot of information around the client, right? Client needs, lack of resources. My question, what makes me curious is if there's any way to figure out what were the system issues that compounded the inability to get discharged out in a more efficient manner, right? Because I feel like I mean, this data is extremely helpful, but ultimately we're being asked to create or evaluate the system piece. And so if there's any way to get more information about what the system barriers were, right? So you talked about not having enough residential placements, and that was like treatment of 18%, right? But what was the coordination and what were the variables that if those things could have been improved? Like I'm trying to figure out coordination of care and who's responsible for what, and if that piece is being evaluated with each of these cases as well. Thank you.
Great. Thanks for that question, Janelle. I think I would kind of echo what we were saying before as far as refining the definitions. We did, as Kristen mentioned, we tracked over 30 some reasons for delays. And so I could follow up with you, Janelle, to kind of talk through all of those 30 reasons to kind of to see if we have those reasons are addressing the questions that you had as far as like system barriers.
That would be, I would actually love that, Nathan, because I feel like this population isn't going to go away. We have to figure out a system to support it. And until we can figure out those variables that aren't as strong as they need to be, then we're going to kind of stay in the same predicament. So we need to get some very actionable steps to change the outcomes for these individuals. Thank you.
Great.
I think Stefan has his hand raised.
Yeah, I just wanted to add that it would have been ideal, of course, for you to have the report in front of you with the results. Unfortunately, we couldn't quite make it work. But the kind of question that you just asked about system barriers, or Laura, the question you asked about definition that helps us include children more systematically in the study. We are hoping maybe once the information is released that you see that as an invitation to think about whether a future study is useful and to what extent our data collection protocol or the partnership with hospitals should be modified to take in additional information. The goal is not to document the same problems, but really to see if we can collect the kind of data that ultimately is needed for you all and people on the front lines to affect the challenges that we're observing. I think the last thing we want to do is do a study that demonstrates not too much in a few years, not too much has changed. So happy to work with you as a group or to work with you one-on-one. Just let us know what you think. One bit of context to make you aware of, everyone who participated in the study and everyone who decided not to faced the considerable burden of completing the study. Adding tasks to their workday in an environment where everyone was already very busy. So it's not a study that takes little time. So we want to be judicious about using hospital staff to conduct this kind of work in the future. So with that in mind, I'll just wait to hear what ideas you have today, or maybe how you might reach out to us to provide additional insights.
And I could just say that although the report is not yet public, the materials about the data collection tool and the trainings that we did for hospitals are available on the MDH website. I'm putting the link in the chat. So if you wanted to look at the different reasons that we asked about or any of those more detailed pieces, you're welcome to look there.
I have a question for you. This is Rachel Freeman. As you look at this study and think about future studies, would there be a value in kind of a deeper dive in the way that I think, Janelle, you were talking about, which is to maybe zero in on some of the individual lives and dig deeper into cost assessment, systems issues, and the other types of things going on with respect to those data points that you're showing disproportionality or, longer delays in stays and that sort of thing. Would that be something that you would recommend given your experience?
Yeah, I would say definitely. I think the advantage of having a metrics approach where we have some quantitative data here that essentially with you that kind of suggests, these are potentially the reasons to kind of focus efforts, but really understanding patient experience, you need kind of qualitative analysis to kind of get at that, to really assess someone's experience in the hospital, but outside of the hospital, and how they're recovering. So yeah, I totally agree with you.
Yeah, and I wholeheartedly agree with that. Sounds fascinating. And we know from our work with the hospitals that, there's a lot of nuance behind these numbers. And so this is, one piece of the story.
This is Janelle again. So I have a question. So with each of these individuals or with each of these hospitals, I would anticipate that these individuals have social workers, they have somebody, right, that's connected to them at some level. Could those individuals be used as data gatherers so we're not putting all the burden on the hospital systems, but it's really some of the other individuals involved in these cases that really could be providing some of that data as well? Does that make sense?
Yep, that does make sense. I can say from my perspective, I suspect that many of these individuals may have social workers, many of them may have multiple case managers helping in different aspects of their lives. And so I think we could do a little bit more digging with the hospitals about who alternative sources of information are. In some of the hospital systems, embedded social workers are the ones that were reporting this information. And in other hospitals, it was like the discharge staff or the intake staff or whoever it is. So
I think that the whole idea around multiple people being involved in a case, I would be very interested to see if that was making it more efficient and effective or more of a barrier, right? So when we think about organized case management and execution of a transition, really the system, the whole idea is the system that we have do we have the right people on the right seats of the bus to manage these people's care? So that would be very interesting for me to see.
I was just going to say, I'm Tiffany. I'm a relocation worker, and I've been working with Randy on this process and I also work with a lot of times with hospitals on kind of difficult cases. And I think not only having the resource of hospitals, social workers, case managers, RN case, there's all different titles for the different peoples that are working those pieces, but also relocation workers. We work with people in nursing homes and hospitals. Like I get some really tough cases that the hospitals don't know fully what to do, and they'll draw in more eyes trying to brainstorm. So I think that's another resource that could be explored because we work really close hand with clients trying to navigate their specific needs and where housing is to get them placed.
Just to let people know, we're going to be transitioning to our next presentation in about a minute, and then we can resume this discussion after 2:15 if necessary.
I just want to quickly say that I appreciate coming here and hearing all this feedback and kind of developing a study like this. And sometimes you think you know the moving parts, but and talk to experts, but there's different experts in different parts of the system. So it's always good to kind of improve our ability to kind of assess what's going on and bring that evidence to policy about things. So I'm just happy that I'm giving these great ideas, and hopefully we can improve our understanding.
I see Stefan has his hand raised. Did you have something to add quickly?
Yeah, I just wanted to add my thanks and wanted to let you know that we'll disseminate the study with this group when we're ready to, and we'll also share with hospitals and hope that in the engagement with different hospital staff and partners within hospitals that there's more for us to learn. The point of the study is to give you the tools on the front lines to change how things are working and for us to learn about what works. And of course, I want to encourage you to work through Carol Backstrom, a member of this group, of course, if that makes sense to you, but we're happy to learn and hear from you and address any questions that you have.
Thank you. Okay, with that, we'll transition to our the Hospital Association presentation.
Great. Well, thank you, Laura. And and looks like you've got a presentation.
No, I'll take this down. Sorry. I was
Okay.
just picking you up.
I was going to say I didn't know I had shared that one yet. I've got one here that I'm happy to share. But again, Joe Schindler here, Vice President of Finance Policy with the Minnesota Hospital Association, and happy to be here with you all today. And really appreciated the discussion from the last segment and all the work that the HEP team did at Department of Health, especially Nathan and Stefan, and also Kristen at the Wilder Foundation, because again, we've worked with Wilder a couple times on these sorts of reports. And I'll pull up the presentation here, but with that, I will say that this has been a long-term issue. I mean, this isn't the first time that we've studied this dilemma, and it's probably not going to be the last time. And so we're a little concerned because most recently, at least post-COVID, there seems to have been an uptick in some of these delayed days. So again, we did some work with Wilder back in 2016, 2017 with the potentially avoidable days study. And since then, I think the problem's actually gotten worse. And so we see the two problems being, and they've been pretty well articulated already. Number one, there are people who have been hospitalized who are now ready for discharge that to an alternative care site or to home, frankly, in some cases with some home services that are unable to get discharged because of the lack of availability, one way or another, whether it's staffing, facilities, and so forth. And then number two, we've got the problem of ED boarding. So to some extent, we've got a backdoor issue in problem one. In problem two, we've got the front door issue where people are coming into the hospital for certain needs that the hospital really isn't positioned to address, and yet they're stuck, and that's what we call ED boarding. So as I mentioned during COVID, we sort of call this the secondary impact of COVID is after COVID, we continued to see this boarding issue occurring to the point in 2022 where there was more and more pressure mounting. Our hospitals were definitely reporting back to us that people were stuck in a hospital bed, whether it be inpatient or emergency department bed. And so we pulled together a quick one week study that focused on collecting data just to see if we could get some gauge of where things were at. And in that study of just 7 days in December of 2022, there were 2,000 patients that had accumulated over 14,000 non-acute days in a hospital. So we estimated that to be a cost of around $35 million from just that sampling. So this was the basis for some advocacy work that we were doing in the 2023 legislature. And I will say that most of our advocacy work was to try to build out infrastructures for skilled nursing facilities to take on some of these patients, for the IRTSs to expand staffing. So we tried what we could to try and find these resources for alternative care sites. The other piece that was on our list is, since we are holding these patients, there are costs, there's legitimate costs that are being incurred every day by our hospitals. And so at the end of the 2023 legislature, like in the 11th hour, even the 12th hour, they did allocate $18 million to hospitals. As a result of that $18 million, they asked that DHS conduct a survey to be able to identify where these patients were housed and to be used as a mechanism for allocating the resources. Now, the $18 million may sound like a lot, but and I will say this is for the survey actually that DHS was then directed to do was for the period of January 1st of 2023 through May 31st of 2023. And actually 94 hospitals reported over 46,000 delayed days that were or ED boarding days that were eligible for funding. And so that came out to, on average, $391 per day. So not very much money per day for these delayed patients. One thing I will note is on the inpatient side, the only days, the delayed days that counted were those that were past 7 days after a patient was ready for discharge. So there was kind of a 7-day blackout period. And then there was the days that were counted after that, at least for this funding. So that's what accounted for the 35,000 discharge delays on the inpatient side. And then there was another 10,000 emergency department boarding days that were delayed. So the data was collected relatively quickly by the Department of Human Services in June and into July of 2023, and the funding was distributed by August of 2023. So this happened fairly quickly, and I will give high compliments to the Department of Human Services for getting this study done and out the door so that the funding could flow. Now, on that note, though, on the funding, the $18 million only covered less than 16% of the actual costs. We estimate that on any given for any given patient, it's at least $2,500 per day worth of costs that are incurred by hospitals. Some hospitals were telling us it's closer to $4,000 per day, because some patients require 3-to-1 care. So they have a lot of staff covering one individual patient. In other cases, we heard that whole units had to be cleared out to accommodate one particularly high, acuity patient with behavioral health needs. So these are very expensive situations for hospitals to deal with. And certainly, from a staffing perspective, it puts our employees at risk, and that has not been a good situation to be in. It's not the right level of care for the patients that are there. We are simply unable to provide the sort of services that they really need. And so it's the wrong site in the wrong setting. So anyway, based on the survey data, we estimated that the cost could be over $450 million just on the DHS survey alone. With that in mind, and because the survey that DHS conducted was pretty robust and comprehensive, we decided to repeat the study using the same tool, which was essentially collecting record level details. Now, I will say that we do not have the record level details that DHS collected. We have the summary data that they provided to us, which was good information. But we took the survey template and essentially recreated the survey for the next 5 months. One thing I wanted to pause on here is just show some of the data, because I know some people were interested in some of the demographics associated with these patients that were in the survey. And so based on the DHS survey, as I mentioned before, there were some days that were eligible and others that were ineligible for the funding because of the 7-day blackout period, so to speak. But you can see the breakout of female versus male. There was more males that were in the study, at least for inpatient delayed days. And then certainly seemed to be quite a few people that were 65 and above that were, again, in a patient bed ready for discharge and being delayed. But there were a fair number of children as well that were found in the DHS study and in the MHA study. And I will say up front that the data that we collected for the next 5-month period basically replicated not only the survey template, the actual results were almost a mirror image of what DHS came up with in their study. So even though this grid here shows the demographics from the DHS study. It would be similar for the MHA data or the two combined. So this was the inpatient delayed days breakout. And then for ED boarding days, this was the breakout as well. So actually, in this case, I would say that there were more kids that were boarded in the ED as a proportion of total compared to the inpatient stays. So that's where, we're seeing a lot of, well, we'll get into the rationale, I mean, some of the acuities, but as the MDH study outlined, largely these are related to mental and behavioral health and substance use disorder situations. So that was the breakout of that. And then again, going back to inpatient, what we called the acuity, but as far as what were the reasons that were, at least that were identified and collected in the DHS study, you can see that by and large, it was mental and behavioral health taking up the largest segments of rationale, along with obesity, and I can't see on here. I know that IV medications and a few things like that were also some of the acuity measures that were collected as rationale. On the emergency department boarding days delays, much more domination of mental health and behavioral health issues. So that there is a difference between the inpatient holding, so to speak, and the emergency department delays in terms of how this mix comes out. The balance being obesity was in the blue, and then the rest of the acuity measures were not quite as significant as mental health and substance use abuse. Mental health and behavioral health. So again, MHA replicated the DHS study. And so we collected data from June 1st through October 31st of 2023. And we had required, hospitals to submit a spreadsheet with tabs in it for splitting out these two distinct pieces of the puzzle, which are, inpatient delays versus ED boarding. And we also got the medical record number, age, gender, just like the DHS study, and then the number of days that they were delayed. And again, the acuity measures, there's no particular science that went into this other than we did hear this information being articulated by the many people who coordinate discharges within hospitals, including social workers, discharge planners, utilization management. There is a whole slew of people within hospitals and outside of hospitals that were helping to work with patients to see if they could find alternative sites of care. So we collected the data through a secure file transfer protocol, and we use tools to disseminate the data. We merged our data with the DHS data, so we effectively had 10 months worth of actual data. I will say that some of our hospitals had just voiced to us that they didn't dig maybe quite as hard, because this is a very laborious activity to try to find the details of, just identify patients who are delayed for one reason or another. In fact, we tried to see if we couldn't find a more automated way to collect the data, including talking to the EHR consortium, who works with the electronic medical record data to come up with protocols to dig into data. And they were not able to help at the time because there are no discrete measures, unfortunately, of when a patient is ready for discharge necessarily. Some health systems have tried to and have gone ahead and implemented some sort of a standard within their medical records, but not all hospitals have done that, and it hasn't been done in a standardized way. So it's been difficult from that perspective to identify these patients. So as I mentioned before, as far as the results of our survey, we found a similar profile in terms of the numbers of patients who are delayed, both in the ED or on an inpatient basis largely were centered around mental health and behavioral health needs, followed by obesity and some of the other acuity measures that we've listed here. So again, we didn't merge this particular data together, but in the last slide I'll share here, we did have 101 hospitals participate in our survey. So in both surveys, there was a significant number, I would say well over 90% of the hospitals participated. So we feel like we've got a full and complete set of data from hospitals. In fact, some of the hospitals that did not participate said they just didn't have that many, they didn't have any discharge delays. So in that case, we think we're well above 95% representation of 1 year's worth of data. Regardless, we took the 10 months worth of data and we annualized it. So assuming that the data between the two data sets was relatively stable, we could account for those extra 2 months that were not surveyed. And we came up with a total of 195,000 patient days of patient days that were delayed in the hospital. And taking the cost times, or taking the number of days times average cost of at least a conservative cost of $2,500 per day came up with $487 million in direct costs to the hospitals. So first and foremost, this is a major problem for patients to be able to not get to the right place for the right care at the right time. And for our members, for our hospitals, it's been difficult for them to be able to house these patients because it does take staffing. You're not getting reimbursed at all for these stays. And we're more or less knocking our heads against the wall to try and find alternative care sites that are just simply not materializing. Now, some of our members have talked about building within their systems a way to at least relieve some of this pressure, but it is an ongoing problem. And given the fact we've collected the data over time now, we've got at least 4 studies in Minnesota that have really documented the problem pretty definitively. And we've had some conversations with DHS about potential solutions. We also know that direct care and treatment experiences some of the same problems we do. In other words, Anoka Regional Treatment Center and some of the community health, behavioral health hospitals have some of the same problems of they have patients that are stuck in their beds, and they were not included in our survey, but they similarly have patients that are stuck in their own beds that they can't get released to alternative care sites. So all along the continuum right now, we've got shortages of placements, ability to make placements. A lot of it's due to acuity. A lot of it's due to staffing or the right kind of staffing for the kind of acuity. Some of it has to do with costs that are incurred. So, for example, if somebody's got a high cost IV that they are on, and then not many nursing homes want to take that patient because just the cost of the IV alone is going to blow the daily reimbursement rate that the nursing home would otherwise get. So there are all kinds of issues and complexities to this issue, but it all lands on the hospital as the last safety net to be able to hold on to these patients and at least do the best we can to care for them. But it's not the right place for kids and for adults to be in. And we've had stories of patients who have been in a hospital for over a year. That means they haven't been outside for over a year. That means they haven't probably seen family in many cases for over a year. So anyway, I'll pause there and take any questions that people might have.
Before we do additional questions, there are a couple of questions that people have put into chat that I'd like to be answered.
Okay.
I think the first one was from Natasha.
Okay. Difference between mental health and behavioral health. Actually, that's a good question. The difference between the mental health versus behavioral health. I think it was also mentioned potentially in the MDH study. We did not try to over-engineer the definitions of what we were talking about here. We left it to the hospitals to determine based on whatever coding sets that they have or clinical expertise they have to distinguish between the two. Oftentimes there could be comorbidities as well. So in the data that we collected and what DHS collected, you could have multiple comorbidities or acuity levels. So.
And that
Okay.
kind of goes into my next question of,
Okay.
was there one primary reason that had to be selected? And if there was, or if there was multiple, because assuming many folks had multiple, how
Right.
did it default to whichever one, was tied to the inpatient days, allocated?
Yeah, that's a good question. In the bottom line, there was no priority status given to any one measure. So if a record came in and had 2 acuities listed, they both are represented in those graphics. So if they had mental health and behavioral health needs, those are both counted.
And then, Brad, did you get your question answered by Kristen?
I think so, yes. Thank you.
Okay.
Hey, Laura, this is Josh. So maybe then a follow-up quickly, Joe. Would, if there was multiple comorbidities or multiple reasons, is that then, how are the days attributed? So could we then assume that there was, let's say there's 2, just to make it simple, twice as many, did each comorbid or each reason get given a day, even though it was only 1 day, so it's really showing 2 days then, or how is that done? Do you know?
Yeah, that's a good question. Let me go. I'll go back and get that answer for you.
Yeah, I was going to ask the same thing, if it's unduplicated data or not.
Yeah.
Yeah.
Yep.
Thank you.
And a follow-up to that question too would it be beneficial to create a separate category to see the percentage of people with comorbidities that are creating the days instead of individualizing?
Yeah, that could be helpful. Yep. I will say that we, again, this was put together, DHS was under the gun to put together a very quick survey. And so we simply replicated it. So, we didn't go through necessarily a protocol to try and identify all the issues you would otherwise do in a traditional study.
She's true. Yeah. She's actually.
Can I ask a quick question? I think it's kind of along the lines of the deduplicating, but unique patients. So, some people might be readmitting within the window of the second data set that you shared. Is that being accounted for if some of those are the same individuals, they've been readmitted for a chronic, situation or not?
Yeah, it's possible that could have happened. Those are, again, still going to be delayed days, but we don't, well, let me take that back. See, the DHS, we both collected medical record numbers, so theoretically we could look at that. We can look at it in our data set. DHS would have to look at it separately in theirs, and I don't know if there'd be a way for us to do a data sharing agreement to do that deduplicate, or to at least see how many people were had multiple encounters.
I think it's an interesting thing to think about, because it does sound like for some people in these situations, there's kind of a cycle happening where they are able to discharge and then they're ending up back in. So it would be helpful to challenging, because people might be in different systems or whatever, but try to see if some of these people might be the same or not. But I agree that days, regardless, are days that are, being spent unnecessarily.
Kind of in a add to what you were just saying, Jessica, the readmission rate too, because it's my understanding there's a difference between, or MDH tracks the readmissions if it's within 48 hours. as well. And I don't know if that changes reimbursement rates and things like that for the hospital.
And, I don't know if those are, when you say admission, if they come into the emergency department, they're probably going to have another workup. And so depending on what coverage they have, maybe there is some reimbursement for that workup. But then if they are unable to get them discharged to an alternative care site, then they start racking up, days again. So yeah, that could be a little bit of that in there.
Looks like Susan has her hand raised.
Yeah, I just wanted to maybe take a second and step back and try to remember why we wanted this data. And I think we could always get better data. I think we were struggling as a group a little bit, making sure we were focused on the right endpoints post-discharge, the right potential solutions. And I know we asked some questions in the last one about, well, what might be solutions? I think that's where we go from this. We've talked about bariatrics is a specific concern that was a little bit lower, but definitely present. We found really no jail, discharge, and we've talked a little bit about that. So I think our goal, but feel free to correct me if I'm wrong, was to really say, do we know where the barriers are? And it seems pretty common among all of the health systems that it's that post-acute space, and including mental health and behavioral. And I'll just say what I think the difference is between mental health and behavioral as a physician and a healthcare administrator is, mental health is a diagnosis. There's diagnostic criteria for being diagnosed with a mental illness. Behaviors can be much more complicated, like a very old person who's out of their normal environment can be a little bit confused and have behaviors that require somebody to help them, but they're not mentally ill. It's a different kind of behavior, and that's similar in a younger population in, say, autism, which has sometimes behaviors that we wouldn't classify as mental illness. And that's what I think what we were reporting on in that subtlety between those two.
Mm-hmm.
Also, thank you, Joe.
At this time, we can open it up to questions on this presentation as well as the MDH presentation if people still have some.
Maybe less of a question, but more of a comment and a thanks, kind of echoing what Susan was pointing to too. I think this really reinforces a lot of the things that we've been talking about, of what we were speculating based on obviously anecdotal stuff, but also information too, is, some of the common barriers or some of the common reasons that we're seeing. And, I think this just helps kind of frame it up even more. And as we get to the next steps of where we want to go with recommendations and whatnot. So I just appreciate the information and pulling things together so quickly and being able to share it, knowing that obviously there's a lot of work that goes behind the scenes and all of this stuff. So.
Natasha?
Yeah, thanks. I wanted to, first of all, thank you very much to both of our presenters, but wanted to kind of pose a question for the Acute Care Transition Advisory Council members to ponder, and then chairs, you guys can decide, when and if to discuss it a little bit more. But so we've seen, data sets here, and the folks presenting have identified some of the understandable limitations to collecting that data. And so the question that I wanted to pose, and it's a big question, but is whether or not this council wants to recommend a more comprehensive data collection methodology. Like, do we want to, because obviously if we do that, that's going to take time and resources, and we're going to talk to the hospitals about what's feasible and what isn't. So I see, in sort of a perfect world, right, which we don't live in, but in an ideal world, we would be able to have data that, was very much answered some of the questions that people have asked, that was more longitudinal than sample the samples that were done. So there's maybe a benefit to that, but it's at the trade-off of getting to other public policy solutions or funding and resources. And so I think the question that I'm struggling with, or I have in my mind that I'd love to talk about at, whenever it's appropriate, is, do we know enough from the limited data sets that we have to be able to say we know what the recommendations for solutions should be? Or do we also say there are solutions we want to implement and we want to recommend some dedicated funding and, resources from a data analysis, like a rigorous research methodology that hasn't happened as of yet. So that's just one thing I wanted to frame up, because I think that's gonna be an important decision point for us to make in terms of getting to the recommendations that we're gonna be, needing to turn our attention to in the next coming months.
That's an excellent point, Natasha. And I'm wondering if we want to consider that now, or if we should table it till a little bit later.
Well, I'll jump in and say, as we move into the next stage of the meeting, you all are going to be talking about the report and recommendations from what we're learning and things like that. So Laura, my thought is, this might be a great time to be thinking about the conversation Natasha's brought up.
Okay, so should we transition to our work group?
Well, I would say let's keep this group here, and then when we end and move on to the next phase, we can kind of copy down the work that we've done. So we got some activities coming up. So
okay. So is this something we need a motion on to consider, or what is? I'm not sure.
I just think like my thought is, following Natasha's kind of question to the group, is to think about, as a group, what are the questions you'd like to ask these presenters that would help us move down the road as we start to formulate recommendations related to measurement. So what are we learning here today that will help us to kind of set up those recommendations? Natasha, am I kind of in the right general area?
Yeah, I mean, I think there are things that we can take away and discuss from the great presentations that we've had here today. And I do think there's an outstanding question of, does this council want to recommend resources and funding for a more rigorous study? Or, because we do tend to see similar, I mean, I certainly tend to see similar themes in the data with what we're learning at the department. Like, again, do we know enough? So I think they're kind of two separate questions. Certainly, I think there's things that we want to discuss today in terms of recommendations. But I think that study question is something that I would benefit from some group discussion on.
So should we open it up if anybody has comments?
Seeing nobody's jumping into it, I will happily make some comments as I put in the chat. And I'll echo exactly kind of what Brad had put out there too, is, I think it's, and I went back as Natasha was asking that, back to the charter or the first couple slides where we talked about why are we here and what are we doing and what is the point. I mean, I think we have to be focused on solutions. And so it's got to be a both for sure. It's not, in my opinion, it's not we need to get more information before we provide recommendations and solutions. We need to be providing some recommendations towards some solutions now. And then maybe one of those recommendations is, evaluating, some of the solutions that maybe have been proposed, as well as gathering more information where we might think there's still more gaps, but it's got to be a both and type of thing, and less of a way to get more, because I think that we can sit and admire the problem or try to figure it out and try to find the perfect solutions and never actually get anywhere. So it most certainly is in my brain of both, but with heavily leaning towards take the information, the really good information that we already have, and make some recommendations to start taking action.
I'm going to interject. Sorry, this is Jen. I'm going to interject for just a second because I have the job of looking at the agenda and the time and all of that. I think that at this point we would be transitioning into the working session for the council to talk through the action steps for the report. And I pose this to the co-chairs and the council, if this would be a good time to thank our presenters, unless there are specific questions for the presenters, and convene as a council for you all to review your thoughts and discuss your thoughts.
I think that would be good, but Susan did have her hand raised, so I just want to make sure that doesn't have anything to do with the presenters.
I'm good. Thanks.
Does anybody object to moving on to the working group?
Laura, this is Stacy. As a facilitator, I just want to chime in. One question that the public is asking while we have the presenters here is that will the slides be made available for us to post on our website after this meeting?
Yeah, we're happy to share.
Thank you, Joe.
We are as well from the Department of Health.
Thank you.
Any other questions before we thank our presenters and move to the next section? Okay. Well, thank you so much, everyone, for coming and presenting to us. This data is very valuable, and we certainly appreciate your participation in our work here.
Appreciate the time.
Rachel, did you want to transition us into our next activity?
Sure. And I think Jen will be posting. So our presenters are gone now. Is that
I'm
right?
going to take a look real quick just to make sure that it's the council that remains. And there are also some statements in chat that may need to.
I was thinking that too, Jen. It might be good to go through the chat before we launch into the activity.
Okay, so I'm going to stop sharing for a minute. I think Stefan is still on, so I might. In the waiting room. All right. I think everybody else, you're all council members here and facilitators. Okay, great. So I can go through and read some of the chat so that it's in in a verbal format, because the chat doesn't appear in the recording. All right, so
I'm trying to see where
Josh, you already made a brief comment. You probably have other things to share, but you said you have comments, but we'll wait for others. Brad, your preference is yes on both specific recommendations and 2, more funding to better understand the problems, especially in various regions in the state. Stacy posted the question about the slides, and that was addressed. The slides will be available. Jessica, I would agree to both, or phased approach. 1, we could have some recommendations that are likely emerging already from the information we do have, but 2, need additional data, agree on regional needs for both data to inform more information and to know how we would measure improvement over time. And then Carol said, I think it's a both and. We need recommended solutions, but also need to keep monitoring the situation. And Susan, my comment is pretty simple. Getting more data always sounds helpful. My org looks at it in incredible depth, and no matter how much data we have, and we probably have more than almost anyone else, the patterns of significant volume are the same over time. The solution requires money and process. More data won't get us much that just asking health systems wouldn't get without more data now that we have some basics. And Natasha will be right back. I think that brings us up to speed on the chat.
Yeah, and I guess I would ask Janelle, as because you asked a question early on about, what is missing in the data that we do have right now and where we should be headed. So kind of want to make sure that as we head into this activity, we remind ourselves some of the things that you mentioned.
Thank you.
And just to close the loop on the chat, Natasha is back.
Okay. Do you want to go ahead and put the slides back up, and we'll go to that section. So just as a reminder, we had action steps of getting the literature review kind of over to you. It got a little bit delayed due to the holiday season. Sorry about that. But we have these steps that we had mapped out in the past that Jen recorded for us, and it starts out with the more recent at the bottom. So during the July meeting, council will hear the reviews. So we saw the presentations. During July and August, we'll be doing the focus groups and interviews. I'm going to give you an update on those today. And then during the August 14th council meeting, the council will meet and review the draft report. So this is kind of our operating timeline. And during the September 11th council reviews, like all of the final recommendations we have, and then submitting the final report. I'm just looking to see. So as we go to the next slide, this is, I think this is the one I redid, right, Jen? Oh, I guess it's in the other, it's in the box folder, right? I put the
I'll pull that out quickly. Sorry.
No. As Jen's doing that, I just tried to make it a little bit easier to see the flow. And as she's doing that, I'll give you an update on the literature review. First of all, you all have that front end. It was kind of what we had presented at the last meeting. And we know that it kind of came in late, so probably didn't have a lot of time to get that read yet, but please kind of go through that. And our discussion was to send that your feedback individually via email to us at ICI. So we've got that as a plan to move forward. The method section is done as well, but it just hasn't been incorporated in to send to you yet. And that's because in order to do the focus groups and interviews, we had to start with what we call an IRB, an institutional review board process at the University of Minnesota. And that's basically mapping out what the process should look like to do the focus groups and interviews and make sure that we're protecting our participants and we're using sound methods for keeping data private and all that kind of stuff. So that has been submitted to the university and it should be back any minute. We did get asked to put the full kind of proposal together, although it will be exempt in the way that I've written it. Now those are in the slides, so I'll make sure that when Jen, you get those slides up, we'll go through that part of the process. So the long and short of it is that with the IRB process, this kind of human subjects protocol process, we chose to do a fast track that is meant to make sure that we can get the focus group started. The thing that we did was ask for interviews and focus groups that would be focused more with county professionals, providers, family members. We left out sort of the people with lived experience because we felt like that might take a little bit longer to get through the review process. So I'm going to talk about that in a little bit and how to get to it. But if you could go back to that table, there you go. So the operating timeline is what I was going through. And this is just meant to kind of give you a sense of how we're proceeding through to get the report finalized. And we have made a suggestion to the council to consider here. So if you look at July, we've got the history and background. You're looking in that and giving us feedback. We have the institutional review board process awaiting approval. And then we've got a discussion from the last meeting of having some working group members help us with the report and with the focus group. Those were things that happened at the last meeting. So that's for this month. And obviously we're right in the middle of that. We've got August where we will have the methods section will be done and over to you. The current findings will be reported as they come in. So what'll happen in reality is as soon as this IRB approval comes in, we will be getting those flyers that we talked about out the door and running. And as soon as people sign up, we will be setting up the focus groups. So we're going to try to move as fast as possible and then do interviews as well to just kind of be flexible. We've set up in the IRB, and I'll go through that in a minute, 2 focus groups statewide, and then to rely more on the interviews to kind of get the different folks that we need. And that was just a matter of timing, given that we're kind of proceeding through this time period. We will be meeting with these groups, the smaller group that volunteered for the report, and the smaller group that volunteered for focus group direction. And I don't know, Jen, that was in the meeting minutes. Let me see if I can find them real quick.
What are you looking for in the meeting minutes? I can find it.
People that volunteered for the report. I think it was Jessica, Brad, and Josh maybe for the report. Do you remember?
I'll find it and put it in chat if that's okay.
Yeah, that'd be great. I just want to make sure people remember, and if something's come up and you can't do this, the idea was to have a smaller group kind of working on things in between so that we can keep things moving. And I know they're in the meeting minutes, but it's a pretty long document. So just looking to see if I can find it real quick.
I'll get it in a second.
Okay, so as Jen's looking for that, just know that by September, that's when, we should have a lot more of the report in its final form. The analyses will be in its final steps. We'll have, and we actually have an executive summary for you today. What Jen and I've been doing is trying to grab recommendations that you've already made through the last meetings, and also possible recommendations to consider from the literature review, so that you all can start deciding what you want to put into the executive summary with its recommendations, and kind of continue to build that as we get more and more data coming in from our community partners, sort of part of the process. One of the things I thought about, for instance, today, as we were listening to the folks who are conducting evaluation studies, is that we might want to have some of the interviews kind of focus in on what their recommendations are for proceeding forward with measurement. So that could be something for you all to consider. And we'll have an activity in a little bit about those kind of things. We will put together the rest of the appendix sort of sections. Those are going to be things like the interview questions, other types of things that come up that are helpful. And then the proposal for you all to consider is, right now, the meetings that we have are today, August 14th, September 11th. And I think there was some suggestion that maybe we meet at the very end just to kind of close and celebrate. And that would be either at the end of September or beginning of October. And we're supposed to close October 1 or 2. So I wanted to just, before we move forward, kind of get your sense of whether you all think we should move forward with an October meeting to kind of close everything. Would that make it feel kind of a little bit better as far as closure? And if so, maybe put in the chat whether you got a thumbs up or not. I don't think it requires a motion to add a meeting. So we'll just do a quick check to see what your thoughts are. Or you could share right now too. You can jump in and talk.
I think as we somewhat discussed in the chair meeting, I think the October or end of September meeting would be appropriate.
Okay, good. All right, and I see lots of thumbs coming up. It's always fun to see the little emoji thingies. Okay, but Carol goes for the yes. She's not putting the thumb in there. All right, so let's go ahead and go to the next slide. I think these are the IRB summaries that I was ad hocing.
Rachel, I'm just gonna I'm gonna put in chat the folks who are doing the primary detailed review of the report, but also we'll just put in here a reminder that everybody can provide feedback and review, but remember to send I'll put my email address in here so that you all are complying with the open meeting laws, that when you do provide feedback, email it directly to my email, and I will get it to the co-chairs and to facilitators so that your feedback can be incorporated.
So the key is not to do a reply all with your edits, just to send them over to Jen. Is that what you're saying, Jen?
Correct. Yes, that's a much more efficient way to say what I said. So
It's
yes,
just my
correct.
real language. Understand things. I get confused easily. Okay, we did the operating timeline, so we'll go next. All right, so this was what I was telling you about the IRB, Institutional Review Board process. The thing that is a surprise to me, because we started out, like I said, with just like county members and members, providers, folks that are involved in providing services, county, state people. These are folks that oftentimes this is a kind of a lesser study sort of approach. It's a little bit more informal. But I think because of the gravity of the council's responsibilities, they did ask for a full map out of the protocol. And so we submitted that in June and then got asked to provide a little bit more information, and we're just waiting on that. That should come through anytime now. And once that happens, the thing to know is I put the flyer into that process. So I know we had some discussions about creating a flyer, and I had to go ahead and put that in a little consent sort of process, which we're going to show you today. So there's some things that we can't change about the IRB process unless you want to like just move it all into the next sort of time period and make it as a recommendation within the report. The people that we left out for now was people with lived experience, people who might have sort of experiences that make them feel more vulnerable to being interviewed in a sort of process like this. So we recommend that as, we can start that process, but we may or may not be able to get it all done before we have to write the report up and finish it. So that's kind of just one of the drawbacks. Now, it could be that if another group wanted to proceed forward with it, that they could do so. It's just that the university, we have to kind of follow this protocol. So if you go to the next slide. These are the questions that I put in. Now, this is a qualitative study, so all of these we can dig deeper into, but these were the actual questions posted into the IRB. What are the most common barriers to acute care transitions that occur in your region? What challenges have you encountered related to this topic personally or in your professional role? What could be done to improve transitions for people who encounter barriers returning home? All of these things you can dig deeper and have follow-up questions that relate to counties or that relate to other folks. But these become sort of the anchor questions that we're asking. So we are asking about what measures or data sources would help the state to better understand the challenges. Have you experienced geographic, racial, ethnic disparities personally or in your professional role? And how can the state address these kind of issues? So those are the questions that were placed into the IRB report. All right. And go ahead and go to the next slide, because I think this is where, yeah, so this exempt process is going to, kind of really force us to either put in the recommendations or move forward as fast as we can to kind of do a more intensive proposal or protocol, which we can certainly do. And then the list of people that we've got that are listed kind of in the flyer, anybody who's working, providing services, or is a family member, caregiver that it has experienced acute care barriers to transition kind of issues. And let's see, next slide. I just want to go through this before we hit the activity. So the flyer is on the left-hand side, and we can definitely make it a little prettier. And then the right-hand side are the kind of consent sort of issues that we will share with everybody as they go through the focus group and interview process. And I don't know if you want to go through all of those in detail. We could do that now, or we could do the activity and come and circle back to it. What are your thoughts? You want to take a look at those, or just maybe review them later? What do you think, Laura and Josh?
I think it would be good to move to the activity just so that we can get some things done, and then we can provide feedback on that, like, to the facilitators.
Yeah, I think that's a great idea, Laura. I don't want to spend a lot of time on the details. Just knowing the details are being handled is always a good thing to know. Anybody else? Go ahead, Josh.
Pause here. So we're at the break time, and I also know that at 2:55 is when we had stated that we were going to do the public comment. Would this be an appropriate time to take a break, tee up for the activity, and then come back and do that after the open session?
Yeah, that sounds great. Is that everybody else in favor of that approach? I think it's a perfect. Okay, so we'll take 10 minutes. And so that's 5 till. Okay. Thanks, Josh. All right, taking a break. Come back in 10 minutes.
All right. Should we start to pull everybody back here? Give it 30 seconds. All right, so at this point, well, I don't see Natasha there. But at this time, we'd like to thank like to provide an opportunity for the public to comment for those in attendance. It doesn't appear as though there's any in attendance there at Andersen. And then just a reminder for those that are viewing live stream that you can provide comment through the email address listed there on the screen. And then those will be shared, as mentioned earlier, with all the council members and incorporated into themes and patterns, and will be considered when the council develops its recommendations with the final report. So, seeing and hearing no open session comments, turn it back to you, Rachel, and get back to the activity.
All right. Well, we might pause when Natasha comes back. I don't think anybody's there either, but it's always good to check. And if you're watching live streaming, be sure to send us emails. We are very much wanting your feedback. So, okay. Well, we can always come back. Jen, do you want to take us to, there you go. So we sent you a document that has the underlined sections that have been drafted. So those are the sections drafted. The IRB kind of covers the methods. They just haven't been incorporated in yet. But those will, some of the sections are already written. So we'll have that done in the next few weeks. And then the key thing, as I said before, is getting the green light to move forward with the focus groups and interviews. And so this is going to lead us into the activity for today. If we go ahead and go to the next slide. So we are wanting to get feedback from you. And again, send it directly to Jen. She put her email in the chat. And she's also listed the people who kind of signed up at the last meeting. So I guess it's Jody, Donna, Brad, Natasha, Jessica. Those are the council members that wanted to spend more detailed time on the report. And then you can send those emails directly to Jen. So the working session is about the literature review and the recommendation sections. And I think you've put other sections as well. Jen, did you want to elaborate on that? I wasn't sure.
I put other sections in for the council to think about in relation to, if you don't mind me going back a slide or two.
Yeah, please do.
When I queue up let me show myself. When I queue up the activity, there will be boxes to provide feedback on literature review, additional recommendations. And then, as you're looking at that balcony view of the report, if you have thoughts on other sections that you want to have noted now that are kind of at the top of your head, there will be a section for that as well.
Thank you. I knew there was a reason for that being there. So, and then Jen, as we go to the next slide, should I go? Do you want me to go through the executive summary and the recommendations first, and then go to the activity? Is that what you were thinking?
If you want to do the executive summary, that would be great. I have a slide that shows these recommendations in a way that you could actually see them as well.
Okay, well, I can share the document and just kind of describe what I did. As I was doing the lit review, I did do the executive summary, but I felt like it was a little bit premature to send it to you all. Oops, that's not it. Sorry. Gotta find it first. This is the report. And I'm not seeing it here. There it is. Okay. So, you know, the way a lot of these reports from Minnesota have been organized has been to directly put the council's recommendations right up front. And so I put in a little paragraph knowing that this is supposed to be a really quick summary, and then you go into the full report. And so it's got, you know, just the delayed discharge issues, a section on the purpose of the report. And then these are all recommendations that we have talked about, and I didn't feel confident that you all had decided their recommendations. So I don't want you to feel like this is actually a written report. It's more like things to consider around recommendations. So I've organized around like work with community partners to establish systems of care framework tied to the emergency department hospital discharge issues that includes care coordination teaming. These are things that are coming out of things like the lit review and the conversations in our meetings, et cetera, but they, you know, they need to be decided upon. One is invest in funding for time-bound point of contact coordination. So we keep hearing, and I know Janelle, you brought up this a little bit, that a lot of times people will have multiple coordinators, and still we're challenged with making sure that we are coordinating across all of the organizations involved in these acute care barrier sort of issues. So this is something that comes out of the literature that you may consider, creating a protocol definition for a small number of people who are, you know, meeting the criteria, so that a measurement system could be kind of created around this sort of process, establishing a teaming process that allows partners across organizations to attend meetings. And this issue comes up where mental health professionals are direct billers, right? Like they can't just go to the hospital and have a meeting around a transition to help somebody transition out. In a lot of states, your billing and reimbursement end when somebody goes into the hospital and then starts up again when the person is back in the community. This kind of a system makes it very difficult to do the things that Janelle, you were talking about, which is to make sure that people can help communicate and assist with transition planning that works effectively, and allocate funds for the use of temporary resources that can be used to assist with complex cases. So these are more specific to coming out of lit reviews that are focused on transition planning for people in out-of-home placements and other types of issues. So the last piece is a functional behavior assessment, and a positive support training is available for support when those behavioral challenges are occurring that we were talking about earlier. So I'm not going to go through all of these. I wanted to just have it be something that you guys could digest and think about. And we are going to be kind of going through also, and I think Jen has these notes, the other things that you've directly mentioned within the meetings that we've had. So I don't know, Jen, if you have that document that you want to share.
Sure thing. I do. I have it in a slide format.
Yeah, that's great.
And it really is just a summary of the recommendations. It's very draft summary. These could be reworded, I'm sure, but just taken from the minutes from the last meeting that are mapped to the 3 goals of the council. So this is kind of that beginning element of the recommendations that you drafted. The idea for having the working session after the initial lit review is being reviewed, as well as the presentations today, was to also capture any other thoughts that you have in these areas as far as recommendations go.
Great. So we're not going to go through and grind our way through all of the details about what we've said in the past. What we want you to do is, in your own time, kind of have some time to review these that we send to you. And we're going to start the activity. Oh, Natasha's back. as a way to kind of continue working on these, those of you who've signed up for the report, what we will be asking you to do is kind of help us to get something together to bring to the council that more reflects the council members' confirmation of some of the things that Jen and I've collected, so that you can present that and have that discussion in August, to kind of start finalizing some of the things that you've already talked about. Does that make sense to you, Jen?
Right. I think it's really just providing the council an opportunity to, I'll keep these up. And I can transition us into that activity. I think it's also important, and Josh, you can correct my wording on this because I think you're saying it better than I am. But when it comes to the report or any other documents, they're shared with all council members, and all council members are, it can provide whatever feedback that you want. Listing the folks that were listed in the chat doesn't preclude anybody from providing feedback. Isn't intended to do that. Those were the folks that were just volunteered to maybe take a deeper dive. Anybody can take a deep dive, right? But just make sure the feedback is sent directly to myself, and then we'll compile all that feedback and get that back to you all as well. All right. So I will put this slide back up in a minute, but this is, an activity, just a working activity around the report. And I'm going to utilize the Padlet for those who can access the Padlet. If you can't, chat is another way to do this. You can also unmute. We just also wanted to give a variety of ways for folks to be able to kind of think, reflect, and respond. So I will drop the Padlet into the chat. There's a link. And within Padlet, what you can do is when you see that there are, you see that there are these plus buttons here. If you select that, you are able to type thoughts, feedback into that section. So if you have feedback on the literature review at this point that you want to have captured in a concise way, then you can put that in here. You can always email that feedback as well. I think the other part is the recommendations that might be circling in your heads based on the input that was provided today as well. If there, you can insert that into the Padlet or into chat, as well as unmute and share. And then the input on other sections is there for folks who might have been thinking about other sections and thoughts that they had on what to kind of guide those sections at this point. All right. So that was how we set up this activity. If you have trouble getting into Padlet, let me know. You can also put things into chat, but this is how we organize this time to allow you to have some time to work on different sections, or to at least provide some thoughts and input on different sections of the report.
I mean, the other thing is you can just share. I know this group is sometimes preferred to just jump in and discuss. So that's fine as well if you're more comfortable with that.
I'm going to put the recommendation.
Are we at the point where we're like actually doing like the working?
Yep. So you could jump in and share, Laura, or you could go in.
Yeah, I just wanted to share two entities that I feel like we should reach out to with our flyers. The first one is a group home provider. They do provide respite and also like long-term housing for adolescents and adults with special needs, complex behavioral health type issues, and that would be Creative Care Resources. And they're more like centrally located in the Twin Cities, but they do have some outreach into like northern suburbs. And then the other group, I mentioned this in the chair meeting, would be the Association of Black Psychologists, because they have like a unique insight into like special considerations for persons of color for like ongoing supports and things. So if we're looking at getting perspective.
I've added this in, Laura, to additional recommendations. Is that okay, Jen? Am I doing it the right way?
Is actually we have an activity following this as well around interviews for additional interviews or focus group suggestions. So there's another activity for that, and I was adding that input into that.
Oh, that's fine. I just didn't want to lose it.
I think anywhere you put it, we'll figure it out.
Yeah, absolutely. Thanks, Laura. Did anybody get a chance to read the report? I know it came out kind of late and you're all really busy people, so.
This is Janelle. The executive summary, I think the first couple paragraphs might need a little bit of tweaking. Using like terms like wellness issues, I think dialing into what that means. Do we mean physical issues, or I don't know what that means. And then the next sentence is around services are not prepared. There's just some language issues there that I think could be worked on.
Great. That sounds wonderful.
I'm just going to throw out, since just some of my initial recommendations. I don't know how to get into that working document that you mentioned, but
I'm writing
based
on.
Okay, so based on what I'm hearing, based on the presentations, I think that I would propose that we consider a regional care management approach, developing or implementing a care management system that all individuals working on these cases can effectively and efficiently communicate with. I would encourage there to be more clear leadership at the DHS level in regards to coordinating efforts with all other parties of these individual cases, including
I think we lost you.
The issues.
We lost you for a minute. Is that Janelle talking?
Mm-hmm.
Oh dear.
Your audio is going in and out, Janelle.
Can you hear us, Janelle?
I can. I think my internet.
Yeah, your internet's going in and out, I think.
Is it something that we could, Janelle, if you have continued trouble with that, I'll put my email in here again, and you can email me directly with your recommendations, and I'll make sure it's documented.
Yeah, your ideas are wonderful. I really appreciate you jumping in. I'm sorry, the internet always does this when you really need it not to, right? And I do think Janelle's speaking to recommendations, so that's really good. I think the attention to language is really super important, and it's reflecting the different kind of people involved. So what we want to do is make sure that we kind of arrive at that common language across the council. So that's one thing that I'm hearing. I have not been looking at the Padlet. Do we have more stuff coming in, Jen?
I see Jessica's hand right now, and then maybe we can go through the chat Padlet.
Okay, go ahead, Jessica.
Yeah, I appreciate you putting this all together. And one thought is I think this has come up in previous meetings a little bit. And it kind of came up from Natasha's comment earlier too, around, knowing the timeline and wanting to make recommendations, also knowing maybe we don't have all the information, we quite need yet. I think at some point could we talk about immediate, like these are things that we would recommend right away. And then like, I know we've talked about prevention and other things that would be great, but maybe aren't, in scope to execute, right off the bat, kind of longer term, goals or recommendations. Like, I wonder if that might help us kind of break down what's something that really needs to happen right away and what are some longer term, goals or visions to move towards.
Would it
Yeah, sorry, this is Natasha. Just wanted to kind of affirm that and thank you for kind of bringing it back to the forefront. In the work that I've done, I think it's really important to focus on kind of both short-term and the longer-term system stuff, because otherwise the longer-term stuff is what's going to really turn the curve in the big picture, but it's not enough to deal with the immediate issues that are happening day to day to real people stuck in the hospital and real providers that are struggling. So I just love the idea of being able to structure the report or the recommendations in both of those categories.
I do think people, Jen, were you going to jump in and move us to the other activity? Is that what you were thinking?
I wasn't. I was going to suggest as we, as facilitators, as we hear the recommendations the council is making, we can share those the same way we're sharing as part of the report, and have you all provide input on those, what you would like flag up to more immediate solutions and recommendations versus the longer term.
I think it's a great idea, Natasha. It sounds like a way to organize the report so that people can feel actions taking place versus the, foundational things that we're all working towards.
I want to read a few things from chat, and then Laura. So in chat, Carol Backstrom's going to provide some feedback offline. Brad indicated he would like to use a footnote process for citations rather than the parenthetical process. And so that's a part of feedback on the formatting aspect. And Brad agrees with Janelle, is going to email some recommendations because of the audio. And then Brad agreed with a short-term recommendations plus long-term aspirational recommendations. All right, Laura, your hand's up. You want to share?
I'm thinking if we're trying to do short-term versus aspirational, I think maybe the data sharing and transparency of what's actually available in the different areas might be a short-term priority, because then people have more access and understanding of what's already there. And then for me, the second thing would be to ask for more funding for training and or staff reimbursement for these community resources as well.
I'm just taking some notes if you see me looking in the display.
So as we think about the presentations from today, what are your thoughts about measurement and how we might set the stage for really thinking about the measurement issues that might be recommended?
What do you mean by measurement?
I think, what we've heard from MHA and MDH, and we know that it seems like from what I'm hearing from them, there's been sort of this coordinated building since 2016, sort of these ideas around evaluation, but we've also had discussions today around what might actually move us forward in a better understanding of the challenges. And I know that Janelle kind of spoke to the fact that there's, getting the data on some of the systems breakdowns, for instance, would be like really helpful to dig in a little deeper. So kind of just opening it, this discussion to what we learned today and what you think we should be making recommendations towards.
So would that be aspirational then? Because that would be a more longer term effort, correct?
Well, I think I like what Natasha said, which is there are short-term and there are long-term, and there could be short-term measurement issues and long-term measurement issues. I'm not sure. That would be something to explore.
Because I feel like the data set that you're talking about and the evaluation would be a more longer term effort versus some of the more shorter term things would be clearing up some of the transparency issues and then also the redundancy issues of assessments and things like that, so that it's a more linear process for those.
Also to think about it, Laura, is to break it down. So if you want to get to the long term, what
care management establish requirements of how to do that can be utilized.
Janelle, is that you? It sounded like you were connecting again. Sorry, I kind of lost my place, Laura.
Rachel, I was just going to suggest that maybe this is reflective of the conversation that the council had earlier about this dual approach that Natasha had mentioned of making some specific recommendations, but then also, where folks were saying it's a both and needing additional information and creating that measurement approach that could be, could also happen now to allow that measurement in that longitudinal way for continued long-term goals.
Yeah, like I would say a short-term recommendation would be to look at the measures that have been created already and to have a working group. Seems like a short-term thing that could be accomplished without a lot of extra funds to create some operational definitions. So we're not necessarily saying we're going to create a whole measurement system, but we are saying we're going to try to start becoming more clear to create kind of a unified language. Natasha, does that make sense to you?
Yeah, it absolutely does. And I think we, the complex transitions team at DHS has started doing a little bit of that as we can, which is looking at what are other data sources that are being collected on individuals that are stuck, and how can we maybe align the fields or maybe create operational definitions that can move us closer to, move us along the pathway to identifying that measurement set. So I think a lot of that is possible in a fairly, not as a resource intensive way that a full set of measurements might be for our more aspirational or long-term interventions. So I guess that's a long way of saying, yeah, that makes sense to me. And I think we've got some work in that space already going on, and to be able to kind of memorialize that in a report to say we should keep doing that more and we should investigate this data and this data, if we get that far, would be really helpful to give us a little bit more direction.
Yeah, that makes a lot of sense. So if we were going to craft something for the short term, it might be that we create a working, what would you call it, Natasha, working team or some sort of term that would help us kind of bring together people that are already engaged in measurement. That would be
like a short-term data measures work group, or that's probably not the right name, but something like that. Because we do have different groups, both in the public and private sector, that are capturing some of this data. So in the children's space, the Children's Mental Health Collaborative Hub is an example of that, where they are capturing individual level data and aggregating it and then sharing that back out through infographics, for example. And we're doing something a little bit similar in DHS. And when we got together and sort of talked with them, we realized there's some areas for alignment in terms of how we collect data that would allow us to more easily compare across our data versus the Children's Mental Health Collaborative data. And that just gets us one more step on the journey to a more aspirational data set. So I really like that.
Okay, so then on the short term, it's also kind of thinking about who the partners would be, because it sounds like you've got some ideas from groups that are doing some really important things that would be almost like a systems of care connect, so that we're actually having some conversations about what we're already doing, how those measures are being created, and then have that collective decision about common language. That would be really cool.
Yeah, and I think so yes, there are groups that are already, again, public and private, working on that. We can keep that per what we just shared. I would also say that, we've now been able to hire on regional coordinators in the complex transitions team. And I think another short-term recommendation should definitely, this is probably obvious to the group, but just to make sure that those regions are all collecting the same type of data or the consistent fields. And I think too about like some of the MHA data where I asked the question about how is MHA defining mental health versus behavior, mental health needs versus behavior needs. And like those two things, depending on how you define them, can mean different things. They can overlap, they can be completely different. And I think no way is wrong per se, but the more we can land on, when we talk about behavioral support needs, for example, we are talking about this. When we talk about mental health issues, we are talking about that, so that we can get our arms around the problem with more nuance.
Would there be an interest from the council in kind of doing some follow-up conversations with the folks that are collecting data to get a little bit more detail? I know the MDH report's coming out, but it might be once we look at that, we have some additional questions that could be part of the interview process.
Rachel, is that a question for the group or for me? Sorry.
Yeah, it was for everybody. So you didn't have to feel like you had to respond.
Cool.
I know you were just talking, so. Anybody else, some ideas for moving forward with the report?
This is Janelle. I'm going to try to talk again, if hopefully it'll work. So I would support that. But I would also say that, like, for me, as I'm thinking about recommendations, it may be really helpful to get confirmation of what systems are currently in place at DHS that are trying to do this work, right? So as we think about system issues and recommendations, maybe there's something already in place that just needs to get tweaked, not necessarily developed. So I don't know if that would be an option, just to better understand that specialized care team that was just referenced, to figure out maybe we just need to do some enhancement and make recommendations off of that, versus me making a recommendation and then them saying, well, there's already a team in place that kind of does that, right? Because that now I've just kind of wasted time. So I don't know if there's, you could send me to where I might find that information, but that would be helpful.
Yeah, Janelle, thank you. I'm glad we were able to get you back on audio. So there isn't a public facing place I can send you that would give you, I think, the information you're looking for, but those are very much the questions, really, really good questions. I know that the acute care transitions team did some presentation very early in the council, but we have hired people on since then. And I think we have a vision for how we think a regional approach could work. And I think it would be very, very helpful for us to come back, even at the next meeting, if we can get on the agenda, to say, this is our vision, or this is what we've put in place so far. What's missing, what needs to change, right? And if, some version of the regional approach that we've been thinking makes sense to this group, we're that much farther ahead in sort of producing the outcome on the report. But I want to be very sensitive to, well, I guess here's what I'll name, that we built this team with federal money, and we built it very fast. We built it under a tremendous amount of really fast moving different dynamics. And so it might be that some of our thinking isn't going to hit the mark, or some of the ways we've been envisioning it. And so I really am looking forward to getting some feedback from this group on again, in our current approach, what's working, what's not working, because we haven't really started the regional work yet. We've been focused on getting staffed up and we have right now 3 regional coordinators. And that's probably not, those regions are probably too big for the long run. And we have different, I think people have different, very valid ideas about how to organize ourselves regionally. So I think kind of the first question is, do we need a regional approach? I think the answer is likely yes, because it's a very big, diverse state, but I think that's one question to make sure we have consensus on, that it makes sense to take a regional approach. And then the second question, or the following questions are, what do they do in those regions, and how geographically should those regions be organized? We're organized right now just by how many staff we were able to hire. There's a lot of particular thinking around that. We've gotten some feedback from counties about using the adult mental health collaborative regions. We've heard feedback from other sectors that it might, from Brad, that it might make sense to organize around the judicial districts, because then we have a better connection with law enforcement, and that certainly becomes important for some populations that are stuck, or people that are justice involved, right? So there's lots of different ways to, I think, rational ways to organize the work, but look to this group to help us get more concrete about, is the way DHS is currently organizing it the right way, or do we need to make some changes? And then are there different resources needed to accomplish those changes? And then the second place is, what do the regions actually do, and what's going to be the most effective? And I think that data collection in the short term is but it's a major function of that too. Is the idea is that we'd have regional teams that are collecting data at an individual level, de-identifying it, of course, and then pushing that data up to the state level in an aggregate way to drive future public policy, resource investments, programs, things. That's sort of the high level vision, but we can definitely come back and share our thoughts and where we are, and get some good feedback from all of you.
That sounds fantastic, Natasha. I think that would be very helpful. And along with what you just referenced, I think an also really important piece when I think about it is what systems are being used, because we all know that we are all stretched, right? Let's just be real. So is there a case management system that can be utilized for all patient or clients care team to be able to get into? So you're not because I think about this, all these calls going back and forth and all this coordination going back and forth. Is there a system that can better hold all that information and reduce the burden and make the case management and the coordination efforts go more smoothly? So that's just also something to think about too, are what systems are being used, and if that needs to be addressed as we look at the potential for regionalization. Thank you.
Laura, sorry. I would just call your attention that we're going to have to switch to another topic area, but I don't want to interrupt people. So go ahead, Laura.
So on the kind of on what Janelle and Natasha were just saying, the overwhelming theme that comes out to me is that all of the things that are going on are very disjointed and not very transparent. So I think the forefront should be focusing on how do we connect all these pieces and make them transparent so that those doing the work know what each other is doing regardless of where they're located.
Yeah, that's perfect. Thanks for summing that up. Was somebody else about to jump in? Because I heard another voice. Okay. Well, let's, Jen, do you want to take on the next activity real quick? It's kind of like we've been crossing over a little bit, so that's okay too.
Yeah, we wanted to include an opportunity for additional input on focus groups or interviews, since we're waiting for that final approval from IRB, and once that goes forward, we'll just get going. And this serves as just a quick reminder of what we have here identified as groups for broad groups for interviews, and what questions we have are, what other groups and people and suggestions that you might have for focus groups. in these areas or questions that you would have, follow-up questions, any specific questions that you might want us to address. We will follow the questions in the IRB, but we have opportunities to ask follow-up questions in context of those questions as well. I have a Padlet for this, but I think if we just have a discussion, it probably would be the most efficient route at this point. We're just looking for input, any final input before we start those focus groups on people to reach out to, groups to reach out to. We've noted, Laura, your suggestions, and then any specific questions that you might want to include in here as well.
Randy's jumped in and said county min choice assessors would be valuable resource.
Hi, also, this is Janelle. Are you talking about county social workers? Are we talking about, like, who are we talking about at the county? That's just a huge, broad, you know, we could be talking attorneys, we could be talking social workers, we could be talking child protection, we could be or adult protection, whoever. So I think we just want to come to an agreement of who fits under each of those areas. Thank you.
Yeah, it's a good question, Janelle. And I think it's one of the challenges with this particular project because of the diversity of the people involved in acute care barriers to transition. So we want to make sure that we're trying to reach out to county professionals that are working with, for instance, kids in foster care sort of settings. I really think that keeping it open, Janelle, is probably the best step, given that this is kind of our first kind of rough open sort of call for information and to see who kind of reaches out to us. In the last meeting, we talked about counties in particular and whether there were ways for those of you who are connected to counties to kind of make sure the flyers get out across different areas within the county systems and the different roles. I think that those are the same issues across these different groups as well, that we just need to do a rough evaluation at this point, and then our recommendations need to be just like Natasha said, short-term versus long-term. Like, how do we get our heads around this picture in the way that, you know, I think Janelle, you pointed out earlier in the presentations, like, you know, there are definitely systems breakdowns, and those systems breakdowns are following pathways related to different types of people who are having these experiences, right? So Janelle, I would say write down or send us, you know, your recommendations for county people that you feel are the most important to hear from. I see that, let's see, we've got PCA agencies would be another valuable resource, relocation agencies who are contracted by the counties, home care providers. Natasha said regarding which county staff, I can facilitate connecting with MAC SSA and MAC SSA to see what they think. That's a really great idea. And Min Choice Assessor, she's agreeing that that would be a really good kind of area. Janelle, thank you, saying absolutely. And then Randy's jumped in with waiver case managers, whether it be any of the different types of services. So those are all really great ideas.
Yeah, that's what we're, you know, wanting to your point, Janelle, like, this is a great time to also just for everyone to share what their thoughts on who we should be connecting with. And if you don't have the opportunity to share today, or if other ideas come up, then again, just email those directly to us.
So, you know, what I wrote in the procedures in the IRB is that we'd create the flyers, we'd get the flyers out through the state, you know, listservs, but we'd also be having the flyers sent out via different distribution groups like county folks that are on the council or other sort of mechanisms for, you know, just making sure that this gets widely distributed. And then we will have it set up so that very quickly we can start getting focus groups together as soon as the people sign up. I see Laura's got her hand up. Go ahead.
Yeah, you might have answered this in a previous meeting too, but are you going to be sending the flyers out to us as council members? And is it within our bounds, like if we want to hand it to like a person to provide that feedback to the website?
We are asking you guys all to send this out. We've got a small group. I'm trying to go back, Jen, to see where you listed the folks that were signed up for this particular topic area. So what we want to do is have this little group. Do you know where that is, Jen? I know it's way up in the chat somewhere.
But that was the report group. There was another group. Let me find it in the minutes from last.
Yeah. So what I'm thinking, Laura, is as soon as the green light goes on for the flyer, that we reach out to the folks that have signed up to help us with this so that we can really think about distribution. And yes, the council is going to have a flyer where this is just a public document anybody can access. It'll be on a website. It'll be just available. And if somebody reaches out to us, then that's their assent. So.
And when we're handing that out, we should just give them the direction that anything you want to input go to the transitions email.
They can go through the email, or they can sign up in the flyer. That's going to be a link to sign up for the focus groups and interviews.
Okay.
So they could do, that's a good point, Laura. I don't think I put the email in to the flyer itself, that if they just wanted to write something, they could. But that's a really good idea that we can definitely let people know that they have the choice to do.
Mm-hmm.
It's a good idea. Because some of us would prefer that, right?
So we're all busy.
Jen, I'm sorry. I do have it written down as to who volunteered for the focus groups. Do you want me to put that in the chat?
Thank
Jen,
you.
You don't have to keep looking it up.
I appreciate it, Danny. Thank you.
Yeah,
I know
I had
more, but
Danny, I have Sheila and Jessica written in the chat and okay. That aligns with what, in the minute. Perfect.
Cool. All right, let's see if there's any other chat comments.
Randy included waiver case management, whether it be EW, CADI, DDBI.
Ah, yeah, there it is.
Yep.
Great. All right, I think if we're wrapping up, we might actually have a quick discussion. And Natasha, you brought up, which is maybe having a presentation in the next meeting in August. Do you think we should do that? So you've got people that you would reach out to invite?
Yes, yeah, I think if that's amenable to this group sooner rather than later would be helpful. So I one way or another, either Amy the director, myself, or folks on her team can present. So we can make that happen. I will reach out to the manager right now. Amy's out of the office, and we'll get ourselves on the agenda and get them ready for that.
Great. Anybody else that we want to hear from, or we think we should kind of investigate to have at the August meeting? I think by that point we should be needing the time to kind of go through information on what we're finding. So
hey, Natasha, maybe this is still premature, but we're going to be getting to the point where DHS is going to be getting close to having some sort of legislative priorities, or at least thoughts around where things are going to go next session. I don't know if there would be anything to share related to some of the stuff that happened last session leading into next session that might tie into stuff, or if there are things that are being implemented that we're seeing early success with that might kind of, I don't know, lend towards recommendations for moving forward to parlay into a legislative action in 2025. Maybe it's too early, and that's okay if it is, and whatever. But just if there's anything to kind of tee up that way, and August might be a good one, because then things go fast and furiously as you get into September and October, obviously. So.
Yeah, thanks, Josh. So I think definitely as a part of our presentation in August, we can like lay out what passed last session that might have some relevance to this group. I'm kind of blanking on some of the immediate things right now. And we can lay out, I think, some of the resources that exist, for example, in our state grant programs and how long those funds last. which is sort of gonna be part of what the team can bring to the table as well when we talk through it. I think in terms of looking forward to this legislative session upcoming, I think we're gonna be in kind of a hard spot because we can't share a lot about, because we don't know exactly what's gonna go into the governor's budget. And, you know, we have certain periods of time where we can't, depending on the place we are in the proposal cycle, aren't able to share as much as we would like with external parties all the time. But what I can say is for this group is that, you know, we really, part of the goal of having the report due in October is so that we can work through our process to identify the legislative proposals or the resources that might be needed to implement the recommendations of this report. And that can very much either be something that can inform our internal proposal development process, or if there's a legislator that is interested in carrying recommendations or working on this, then it provides kind of a, you know, plug and play. Here's what you think, here's what you should fund, here's what you should do. And then the department can come in the back end and provide any technical assistance on language and what we can operationalize and what we can't. So I would just flag that this report, the more concrete that we're able to be as a group in terms of consensus about investments that are needed or changes to law or other things that would be helpful to implement recommendations. As you all are looking at this great draft report and thinking about what we actually want to bring forward, know that there's kind of a direct feedback loop to legislative proposals. So this isn't the type of report that we would expect to kind of sit on the shelf and inform our thinking. We really want, I think the legislature's intent was to create an actionable, you know, a report that creates potential action items. And I think that also relates back to earlier comments Josh and others made about we need to put some solutions on the table, even if they're not the only solutions, and we have to look towards the long term. Just kind of thinking through that for myself. So that's how I can respond to that. Hopefully that helps a bit.
So Natasha, it sounds like if we were to write something for the long term, it would be more like something that says investigate these things for the long term, and then keep it more like an action. I'm remembering now that the language was all around action planning. So that's going to be important, and having the short term sort of actions that we believe can kind of get started is going to be a really good thing. But then articulating the things we know to be more complex in a way that is manageable for a legislative kind of conversation, right?
Right. I think that's exactly right. Like, you know, I know nothing about this is easy or simple, but to the extent we can get as a team to, here are the top 5 things that we want to do right away. And here's, you know, that we can work on, here's the resources, here's the funding that's needed to support them. That gets that like concrete, we can take that and someone can make that into a legislative proposal and it can go through the process. And then for the longer term stuff, I think it's right. I think it's focus on this, investigate this, and maybe through that process, we identify some longer term funding that's needed to do that. That might be, I think it kind of just depends. But I think certainly the more coherent we can be as a council on finding consensus for the top X number of things that we think would be important to invest in, that gives us the best chance at getting those things actually passed or getting to action items that allow us to start doing that. So it's going to be that discipline of staying focused on the short-term solutions that are kind of within our grasp today, and then setting ourselves up to have that long-term systems evaluation where we are implementing things and then we're checking back and we're evaluating and we're measuring against the data we collect to see, are we making progress? Are stuff we're doing having the impact we want? And if it's not, then we need to, you know, regroup and try something else and have that evaluation process, that plan, do, study, act, continuous improvement lens in all of our work, which doesn't in and of itself take a legislative proposal, but I think sort of sharing how we might think about working through the inevitable conflict between the need for short-term solutions and that longer-term systems thinking.
So one of the things that those of you who signed up for the smaller working group might do with us is come up with something that by the time we get to the August meeting that you all could rate is importance, so that we could get that kind of consensus from everybody about these are the most important things that we'd want to like anchor for the report. Does that make sense? I think that's doable. Okay, that was really helpful. I could just kind of see a little bit better how this needs to get organized. Anything else we need to think about in preparing for the next meeting? Are we okay with investigating an October and or end of September meeting? I know I brought that up earlier today. We'll kind of pursue that if that's of interest. Kind of, we talked about one final meeting that would be like closing the door and or looking for the future. I see Josh is giving a thumbs up. Anybody else? Thoughts on proceeding with a closing meeting? I know it's a lot of meetings. Go ahead, Laura.
I think it would be good.
Okay. You can always throw it in the, Jessica, thank you. I was going to say, put a thumbs up in there in the chat. If you think it's a good idea. Ooh, I think it would be good because that way, those of us who are kind of finalizing can make sure that it's the report that you want and that we've gotten it all kind of organized. Brad says we're going to need it. Excellent. Okay. Well, we'll proceed with that in mind. And I think that's it. Do we have anything else, Jen, that we need to bring up?
I don't have anything. There's nothing left on the agenda. The action items that I have that are new. I'll say two that are ongoing, and that's the review of the literature review draft report. Do we want to add a date by which we would prefer feedback? So we have I like timelines, but I'm your facilitator, so I'll let you all guide that process.
You're not asking me though, right? You're asking the
No,
group?
I'm probably asking like Jessica and Brad and you scroll up the chat and the rest of the council if you'd like an anchor date for providing feedback on that first draft lit review.
Just a quick question, just to kind of work backwards. Is your goal is that you get the feedback from us and then you'd make some revisions before the next time we're meeting? And so then we're probably actually talking only a few weeks out if we're going to be meeting again, and then you need a little time to do some revisions.
Yeah, I mean, if we could give like a couple weeks and that would give us time to make the edits for the next August meeting, that would probably make sense, right, Jessica? That's kind of what you're pointing to.
Yeah.
Brad put a comment in the chat about having to reach out to various stakeholders, so I don't know if that is realistic. Now that we're going to be working on it, I don't. Is that in relation to the report, Brad?
Yeah, I excuse me, I think so. I mean, the reality is that if I'm going to be suggesting some revision to the draft or specific edits, I'll share those as soon as I can, and I might even share them on a rolling basis to get you what we can. But I don't know that I can be as organized as saying to people like in my social services that we represent or to other county stakeholders that I might need some input on. Does this make sense? Does that make sense? How do you feel about this? That I'm going to be able to get it all buttoned up within the next 2 weeks. So
yeah, just remember, Brad, this is just the lit review, so it's not the recommendations. I think those we have more time to, we still need to organize, etc.
Right. And I'm assuming you all are going to send out, you put it up on the screen here today, but are going to send out kind of the working draft on where we're at right now. Okay.
Yeah, it was in the PowerPoint today we went through. So it's got the timeline and where we're at in the process. Jen had it underlined as far as things are done.
I just want to clarify too, and I think Jessica has a comment in chat here. You're talking about what was already sent out, and that is correct. The council should have received the draft literature review, and that's what we were asking for feedback on more immediately than other sections as they're built out.
You're going to send out what you put up on the screen today.
He wants a PowerPoint, Jen, that has the timeline for the report process, I think.
Well, no, what I want is the working draft of the things that you put up there today that included the recommendations that were started to be filled out.
Yeah. Yes. Sorry, Brad. Thank you. I'm just trying to clarify what.
Yeah. So
we sent out a lit review, but what I shared today, which Brad is pointing to, is an executive summary that did not go out yet, right? And the flyer and the consent form process. So those things we could share with you if you're interested. We have a small group that was going to work on, the report, but like we said, everybody's welcome to be looking at these things, so we can certainly send those out. That was part of the executive summary kind of setup that I'd put together, but just know that they're not meant to be the recommendations yet. You guys are creating those. It was meant to organize the process.
Right. I just think it's helpful if we've got kind of where you're headed on things. It's helpful for us to be able to kind of then weigh in with specific recommendations and to kind of tweak it or tailor it, just like we had this discussion today about long-term versus short-term, things like that.
Yeah, and I want to actually hit that executive summary to organize in the way that you all have talked about today with short-term and long-term. It might be better to look at it that way, but certainly we can just send it out as is if you want. I didn't put it in, Brad, to the literature review section because I felt like it would be premature to put down recommendations that you all hadn't confirmed. So at the same time, you need to see them to be able to confirm them. So.
Yeah, and I'll just clarify I'm taking notes on action items just to kind of, I think there are two different discussions that play into the one final report, and that's the literature review that was sent out, and it would be really helpful to get feedback on that more immediately on the lit review component of it. One of the action items that I wrote down, if I'm correct, is that we as facilitators will send an updated list of the recommendations. We were going to send that to the small work group, but we'll also send it out to everybody so that you all can start to rate and prioritize those recommendations. And Brad, that isn't something that we would ask for in the next week or two. The feedback for the lit review would be really helpful if we could get back in the next 2 weeks so that we can then respond to that and get you back a draft by the next meeting. But the recommendation
that makes sense
would take, that's kind of the longer process, right? And where you would want more input. Does that make sense on that one?
Yep.
Perfect.
Thanks, Ben. That was perfect. You did a good job saying it.
The other thing that I have here, so we will get that list out to everyone. We'll also work on identifying a closing meeting date and time. I'm wondering if we could get feedback on the lit review by the 26th of July. Would that be a doable date, or the 29th? I see a head nod, Jessica. All right.
Just pick one.
All right. The 26th would be great. That could give us a full week to work on making those updates before the August. When is the next? We have until how about the 29th? All right. I'll put that in the meeting minutes. And then the other action item that I have is for Natasha for preparing for the next meeting so that we have folks available to you have folks available to present. All right. So that's all that I have, and I know we're a minute over, so I'm going to stop talking and let you.
So I will take that as a cue to thank everybody for coming. Thank you for the discussion. Pass along thanks again to the presenters from earlier for their awesome data and information shared, and get everything done with all the to-dos by the dates that Jen just listed, and we will see you all next time. I call the meeting adjourned.
Thank you, everybody.
Thank you.